Moving on to the next lecture, the topic of the lecture will be renal preservation in upper tract urothelial carcinoma management. Over to the moderators to introduce the speaker.
I have great pleasure in introducing Professor Srinath Chandrasekara, who is the president-elect of SLAUS and a past president of the College of Surgeons of Sri Lanka, and is currently professor in urological surgery at the Faculty of Medical Sciences, University of Sri Jawaharlal. Over to you, Srinath.
Thank you, Ajit. So I think this session, beginning of the session, we've been listening to very dynamic, exciting talks with lots of images and videos. So I think I will need to change tune and start talking about something quite rare for all of us and rather elusive, which is upper tract urothelial cancer. As we all know, this is not a common problem. Fortunately for us, it's not a common problem, and the incidence is fairly rare and accounts to, according to literature, 5 to 10% of all transitional cell carcinomas and about 10% of all the renal tumors or renal cancers that we need to operate on. Importantly, we'll find that there is limited high-level evidence regarding the optimal management and its outcome of this condition. Upper tract urothelial carcinoma, or UTUC, as I would continue to call it, has many challenges. The peak incidence of this problem is in elderly over 70 years, which makes management that much more difficult. Prognosis is not marvelous for advanced disease. Staging is difficult because of limitations in imaging. But again, this is something that is evolving with high quality MRI, CT, and flexible rhinoscopy. I think this is now being overcome to a great extent. And standard or traditional treatment leads to nephroureterectomy resulting in CKD. Now, this is in a background where these elderly patients suffer from many comorbidities, and the contralateral or bladder recurrence rate of TCC could be as high as 40 to 50%. So 20 to 47% is what is documented in literature. So this means that some of these people will move on to developing advanced disease, requiring chemo, and nephron sparing becomes that much more important. Now here are some of the comorbidities that are documented in the literature. As we would expect in the elderly, cardiovascular, cerebral vascular disease, chronic kidney disease, liver dysfunction, diabetes, often coexisting in more than one condition in one patient, which adds further complexity to nephrectomy as well as the management of these patients. So when you look at all this, we all agree that nephron sparing surgery, when it's safe and appropriate, is a logical choice. So let's look at risk stratification and patient selection of this subgroup. And here, the recommendations are very similar to bladder cancer. Risk stratification or high-risk cases are classified according to some of the information given here: larger tumors, high-grade tumors, positive cytology, obvious invasion of lymph node and imaging, hydronephrosis. Although this is controversial, hydronephrosis has been challenged by some workers, sessile or flat lesions, multifocality, and according to some guidelines and literature, histological subtypes and vascular or lymphatic invasion. So the EAU as well as the AUA has gone on to categorize upper tract UTUC into high risk and low risk. And again, AU has gone on further to subdivide low risk or low grade disease and high risk disease into further subcategories. So this is based on the same parameters, and we can now divide these population of patients into low risk and high risk categories. So how about nephron sparing surgery? Yes, like with renal cancer, nephron sparing surgery, the indications can be divided broadly into two categories. One would be an imperative or mandatory requirement, and other by choice. Now the imperative indications, like with renal carcinoma, would be with single kidneys when there is bilateral disease, which is rarely sometimes seen, chronic kidney disease or established renal impairment, or very unfit patients who are not suitable for radical surgery. When the correct indications or the low-risk categories are diagnosed, this will become a non-imperative indication for nephron-sparing surgery. So treatment options: ureteroscopic ablation, percutaneous resection, and segmental excision of the involved segments of ureter particularly are the popular choices in treating these patients with nephron-sparing options. Prerequisites: as mentioned before, thorough assessment is mandatory because it can be sometimes difficult to carefully stage these problems, and it is generally considered that the final histological confirmation is the best form of local staging. So therefore, we all need to adopt multimodal staging, CTs, MRIs, direct imaging, whatever that is possible for adequate staging, and ensure that the patients carry the correct indication or localized disease. I will come to the last point later on. Careful counseling and consent of the patient and adequate motivation of these patients to undergo rigorous follow-up protocols is very important, and it is a prerequisite before embarking on nephron-sparing surgical options for upper tract TCC. So moving on, ureteroscopic ablation is a popular choice, but it is mostly appropriate for smaller lesions in the ureter, renal pelvis, or sometimes the calyces. And the recent popularization of digital flexible ureteroscopy has really contributed to quality in the management of these lesions. And of course, the addition of thulium laser and the more powerful lasers again has made management of these upper tract lesions through endoscopes that much more easy. I remember as a young trainee being entrusted to do one of these cases in the UK where I was trained, and I think we used a neodymium laser at that time, and it was near impossible to fulgurate these lesions. But we know that we are fortunate to have the high-powered holmium and the thulium lasers now, and it is so much more easier to fulgurate these lesions using these newer technologies. Use of access sheets can facilitate better manipulation and also for whatever theoretical concerns, minimize the contamination of the lower tract or the bladder during surgery. So use of access sheets when appropriate is highly recommended. For larger lesions and higher up lesions, antegrade approach is also possible, especially for large lesions. And when tumors are located in the lower pole or size difficult for flexible ureteroscopy to access. Now, these two images are not mine, they are from Nishant Elena Pathirana, our good friend, and this is in a 90-year-old man who had very severe bleeding from the upper tract due to a large renal tumor, and he was not fit for any further surgery, and he used a high-power laser with Moses technique, and he fulgurated with very good control of bleeding, and the patient preserved the kidney and went on to live a normal life. Percutaneous resection is an option, so although I must admit that I have not had the experience of doing many of these conditions, but it is well documented. It is most appropriate for bulky upper tract or upper ureteric lesions, and more importantly for renal pelvis and calyceal lesions. And here you see once again some of the images of successful treatment of this problem. So en-bloc resection is also now, just like the Chinese TURP, is a possibility, but there is minimal data on the safety of this condition. Oncological outcomes are not inferior to radical surgery in these groups treated with endoscopic options with clear evidence towards preservation of renal function with the minimal access or nephron-sparing techniques. All these data come from retrospective series, and I do not need to say that there could be a lot of selection as well as or selection bias in this and lack of information in this retrospective studies. So let's go to segmental ureterectomy. I think Malika spoke a lot about ureteric surgery, so we are familiar with various things that can be done. Segmental excision, end-to-end anastomosis, psoas stitch, Bowery flap, reimplantation, the whole works is there, including on rare occasions, bowel interposition and auto-transplantation. Mallika spoke very eloquently about these things, so the surgical techniques are pretty much the same, with an added advantage of lymphadenectomy in high-risk patients when necessary for these category of patients. Now, this is certainly my favorite technique of managing upper tract urothelial cancer with nephron-sparing methods, because for many reasons. Now, this is a patient we treated. He had a lesion in the mid-ureter, as the CT kind of shows here, and the retrograde showed this lesion. And after counseling, the patient opted to do a segmental excision. And as Mallika once again quite rightly said, bringing these two ends together was not really good. So we wanted to, he had CKD, so we did not want to take chances. We ended up doing a mini Bowery flap. He had a fantastic outcome, and we had a very good specimen showing T2 disease, and he has remained stable for over 2 years now. So outcomes again are no different from radical surgery, better renal function or preservation of renal function, and no difference in overall survival. Again, data is retrospective. Adjuvant therapy, just to touch on mitomycin, which is now being increasingly used, but there are reports that those who receive mitomycin following upper tract preservation have a tendency for higher ureteric strictures. Again, mitomycin gel, or that's called gel mito, is now licensed for use, and this is mostly being propagated in the United States. I do not have any experience in using gel mito, and there are newer forms of photodynamic treatment modalities which are under trial but not in clinical use. Now, to wind up, follow-up is the biggest challenge. So that's why I mentioned that any patient who's not adequately counseled for rigorous follow-up with regards to the risks of recurrence should be taken up for nephron-sparing surgery with greater caution. There are a few reports of large series emerging that the first look, relook check cystoscopy at 6 weeks following upper tract laser or endoscopic treatment has been significantly high, where 20 to 30% of people have were found to have residual disease requiring further treatment. So I think these factors must be very carefully explained to patients and motivated as well as counseled with regards to rigorous follow-up protocols. So this includes a 6-week follow-up ureteroscopy and imaging for high-risk patients, certainly 3 to 6 months follow-up with imaging, and ureteroscopy if required, depending on the risk profile, cytology, CTs, and MRI. So this is the crux of the matter, follow-up. Careful follow-up, because they do have a risk of recurrence in the treated segment. So in conclusions, ladies and gentlemen, nephron-sparing surgery is an effective modality of treatment for well-selected patients or well-selected subgroups with upper tract urothelial carcinoma. It is not a blanket option. Or the reverse is even more true, where traditional treatment of nephroureterectomy need not be the primary choice for all patients with upper tract urothelial carcinoma. Careful risk stratification and staging is key to success, and it is imperative that the patients are adequately counseled. High-level evidence is not yet available, and all guidelines and larger series will indicate that we need further data before this is further established as a treatment modality. Thank you for your patient hearing.
Thank you, sir. Let me now invite one of the chairpersons to present the token of appreciation and certificate to the speaker.